Dear urologists, good afternoon, one and all. Today, we are showing unedited video of supine PCNL in a child, right from the CT scan, RGP, position, puncture, CM usage, CM directions, how the needle goes, how the urine comes and the guide wire, then dilatation, then impacted stone tips and tricks, and then at the end flexible nephroscopy, and whether to put nephrostomy or stent or both, we will discuss in sequential manner. The video is recorded with cell phone, again emphasizing that the sharing of the knowledge is not costly. Willingness to share, exchange our views is important for future generations. Keeping that in view, I have recorded with the cell phone and I am giving the voice along with the cell phone. At the same time, in between, I will give some clarity at whichever point is required. The case scenario is, before going to the case scenario, due permission is taken from the parents for the transmission without revealing the identity. And also, these type of videos is for only educational purpose, and we should not use this video without permission for any other purposes. So, the patient is young boy. First thing I want to mention is boy, around 5 years, with 1.5 centimeter kidney stone impacted at the PUJ region. So now I will share the screen and show the video completely and explain what has happened with this. So this is a video. You can appreciate here the screen, the stone is a radio dense with 1300 Hounsfield units and meaty kidney. This is a reconstructed view. There is nothing much in axial cut, otherwise axial cut is essential. Now, first thing that comes in mind is RIRS versus PCNL. The important point I wanted to share here is, if you put ureteroscope, if the ureter is not admitting ureteroscope, either you have to put the stent and postpone the case for next time for RIRS, or you have to do prone or supine PCNL. Let us see. I will start the video. With the upper ureteric impacted stone, large one here. When you are doing such cases in a meaty kidney, RIS versus PCNL is the discussion. On that basis, we are going for this surgery. Supine PCNL or prone PCNL is RGP. In supine, same position we can do RGP and take decision. But in prone, whether to inject contrast before positioning or not is the controversy. Here, it is supine position. So there is a kink. There are two kinks. So going like this, reaching this and making, especially in this hydronephrotic kidney, unnecessary RIRS for 5 years baby. So opt for PCNL. No guidelines can guide this, but your common sense that this type of an, you can put stent and do it. Why do anesthesia for the patient? Do proper supine PCNL. So this is a point we want to mention here, that if the ureter is kinky and not straight, and ureteric catheter is not going up to the stone, and ureter is not very wide, sometimes you can take decision of supine PCNL in the same position. But only thing is, consent should be taken for both. If the consent is not taken, you have to put stent. If you have told only about RIRS, we have to go for stenting and try later on. In this case, RIRS is feasible. In fact, I was planning to do RIRS, but because of the meaty kidney and most important, socioeconomic status of the patient was not that much that they come again and again, we decided that we will give one-time solution for the patient. Sometimes, yes, RIRS is little more costly than PCNL because of the equipment and the method of the procedure. Now coming to the position, same position we will do ureteric catheter as well as the RGP and puncture. That we will share here. Tried ureteroscopy, it is very tight. So option was only stenting. So same position patient was there in supine. So this is a position which most of us think that what is the position, what is the position. As many of our previous videos have shown, ipsilateral side, in this patient we are doing right side PCNL. It will be slightly on the lower side leg. Opposite side normal lithotomy, and one towel, folded towel at the below the shoulder blade will give this position. It is supine with little tilt. Little tilt means how much? Maybe 25 to 30 degree. With that, you can easily see the 12th rib, 11th rib, paraspinal region also. So let us see. So decision can be taken spot to go for the supine. In the contrast, I am holding this. I have ultrasound spare, but here I am not using it because the system is very much dilated. I will go more posterior, below the posterior axial line, not anterior, to be on the safer side. If you use ultrasound, it is safe, but in this case, I am not using ultrasound. Is keeping like. See, in supine and prone, the main difference in keeping the needle is needle will be oblique in supine PCNL because patient is not flat. Whereas in prone, needle will be not oblique, it is horizontal. So needle length appears more on the surface anatomy. That is the first worry, no need to worry. Like in prone PCNL, you put in the direction of the calyx, that's all. Let the any rib come, let any position come, no problem. First step is in 0 degree, you put the needle in the direction of the calyx. Let us see here. See, there it is quite below. Quite below. So automatically you have to go up like this. Now it is seen. This cup is seen. This cup I am aiming. Middle calyx is safe in supine PCNL. Once you keep like this on the surface, the needle appears long length from the skin. No need to worry because it will not travel obliquely. It will travel horizontally in the body. Please do not worry at this juncture about the length of the needle. Like any other PCNL, prone or supine, you keep the needle in the exact direction of the cup, in the center of the cup. That is the first step in 0 degree. Calyx, it is coming just below the rib here. Normally in prone PCNL we go below the rib. So in this position more posteriorly, I am putting a blind. This is the blind part of the supine PCNL, in prone PCNL also. Because it is triangularization method, you have to approximately go somewhere needle around 3 to 4 finger breadths, but nobody can tell. The approximation is in supine PCNL is much easy because it is horizontal. Practical guideline here is below the 12th rib, if you put in the line 1 or 2 centimeters below the 12th rib tip, if you go for initial puncture, you will be very, very safe. Maximum 2 finger breadths below the tip of the 12th rib, exactly like in this case. You can observe one spot to go in that direction. When I kept like that, it was going into the, that means this is horizontal, not above or below. I will go horizontally like this towards the calyx. Show the calyx now. Now, Jesus the calyx. Now, tell me whether it is correct direction. Now, I have gone towards the calyx in 0 degree. This is the most important thing everybody asks. If the Siam head is tilted towards the top. Top is the receiver. Top is the receiver, goes to the head end. If the needle is in the same place, you are close to the calyx. If the needle goes above towards the head end, it is posterior. That means you are on the towards the table. Towards the table means back. So in supine PCNL, posterior towards the table, back. If the needle is going towards the head end, it is posterior. If the needle is going towards the foot end, it is anterior. That means you have to remove the needle, change 10-20 degrees direction, automatically you will go into the calyx. Now in this case, exactly it was falling, but I readjusted for the movement of the calyx. This is the second point. First point I told is below the 12th rib, 2 finger breaths. Second point is horizontal. Third point is if the needle is going towards the head and it is more posterior, that is backside. If the needle is coming anterior, it is more anterior. Anterior you should not be there because colon can come. So after the confirmation in both angles that it is there, you can take out the needle and see, or third important point I am telling is move the needle wherever the maximum movement and kidney calyx deformity happens, then you are 100% sure that you are entering the kidney. That I am showing here. Or not, I will ask respiration to stop. I will shift 30 degrees to head end. What will happen if 30 degrees head end? If needle goes down, it is anterior. It is anterior. If needle goes up, it is posterior. Now shift. Now see, Siam, that type of variation comes in supine PCNL. You can tilt the entire Siam up. Why it is dark? It is coming. So it is like this. Now darkness is. Now when the Siam is tilted towards the head end 30 degree, it is still falling. If you carefully see, it is a few millimeter not in the cup. That fine adjustment you can do in 30 degree so that maximum movement of the calyx, maximum movement of the kidney happens. This is the most important point in supine PCNL, I must tell. Watch this next half minute. You see here. Fine adjustment. Now I will like this, whether it is moving or not, posterior, anterior, I am moving. Little bit adjustment I am doing. When it maximum moves, it is not moving maximum. See, now it is moving maximum. Can you see that? Can you see that? Inject contrast Ramakrishna. Can you see that? So now I feel that I have given way. Now what I will do? Inject the saline of contrast. Now hold this carefully in children because depth will be less. See, some amount of hemorrhagic blood is come. Now you will inject saline slowly. You have to guess whether it is acceptable or not. First we will observe for some time because it's in the periphery only. We will wait for with the. If any puncture has blood, it is not a good puncture, but any kidney, if it goes through parenchyma, some amount of blood can occur. Watch for increased darkness, or if you flush, it should dilute. If the needle is crossing the infundibulum, do not dilate. In this case, it is not at all crossing the infundibulum. In children, infundibulum length will be less. So you should be careful to keep at the periphery of the tip of the calyx. Now I will show that. That's why I proceeded. This is, for me, it is acceptable with my experience. So everything is experience. Now what I will do, Siam. Now, see, periphery. This is the most important thing, that the needle tip has not gone into pelvis, has not gone into the infundibulum. Then it is very, very safe. Then you can pass the guide where disastrous injuries will not happen. Center of the cup, few millimeter from the cup in the calyx, usually does not cause torrential bleeding. After entering also, we should be careful. While dilating also, we should be careful. tip of the periphery. Unlikely that a major vessel will be hit. So now it is a little amateur per calyx. Happen to be seen here today. Can you see that? If any guide wire goes into the upper calyx and turns into pelvis, it is very, very lucky. Second lucky thing is if it goes into directly to ureter. But I feel if you are doing lower or middle calyceal puncture, if the guide wire goes into upper calyx and then curls down, you are very safe because the dilatation can be aimed towards the upper calyx and then go inside safely into the PCS direction. Upper calyx curve, never think that it is bad, like this case. And how it is, see, inject contrast, can you see the guide wire? Can you see the guide wire? Can you see the guide wire? How it is going into the kidney? Can you see that? Current and went into the upper and lower. Which is, and next important point is when you are doing in children, remember, dermis in children is very, very, very healthy and elastic, and it does not pierce even in laparoscopy or in PCNL. Cut over the guide wire clearly the dermis. More than rectus sheath, dermis will give problem and the guide wire king. So 0.5 millimeter, 1 millimeter, don't think about it. Even in mini perc, don't think anyway. Either one stitch or no stitch will happen. Does not make any difference to the patient. So please do not dilate without cutting the dermis. There is no need to cut the rectus sheath because it is dangerous. You can use artery forceps like some people do, but the technique how to dilate the rectus sheath I am sharing now. Which is not very dilatation is, this should be kept in the same direction as. See, this is very important. You see the there, this is very important. This dilatation kinking. If this dilator is a flexible dilator, like all of you know, these dilators available with all companies, they are 6 French, 8 French, 10 French, 12 French. Take it for granted in supine PCNL in the beginning stage, you put these dilators to perforate the rectus sheath, not the kidney, not the PCS. Rectus sheath will give away a little bit, so that subsequent dilatations, single step or whatever steps you do, they are not harmful, because in supine you see already the tip of the dilator is abutting the medial wall of the pelvis. If you don't take care, it will perforate in supine PCNL. So you should rotate front and side to side slowly, watching the C-arm. This is the only where you have to require a little more C-arm in supine PCNL, because it will be free in the anterior aspect without any resistance. Observe this. The guide wire is very common company, will do the job. What it does is, it perforates the rectus sheath, quadratus lumborum, any muscle which comes there, it makes a hole, so that further dilatations are easy. Now see here, I am putting again, I am going carefully in the direction of the calyx, rotation movement, see front and back rotation movement, see, these rotation movements are important, not like this, rotation movements are important. That's what size? 10 French, 12 French. This 12 French will make the hole in the rectus sheath bigger, see now, in that direction. The direction should be upward, it should not be like this. It should be up like this towards the calyx, front and back movement, the rotating movement, that's all. Don't go. Stop. I use Alken. See, now after doing 12 French, there are 2 options for this child. Maximum dilatation, better to keep up to 15 French. You have 15 French, the steel outer sheath in companies like Storge and Wolf. This is outer sheath, but they are not beveled. Their flexibility is less. Definitely these discussions have no conflicts of interest. It is my experience I am telling. Whatever the seniors feel, it is okay. In fact, the chat box is open. You can give your valuable experience if you are a senior. if you are a junior, you can ask the doubt. I prefer Alken rod dilatation up to 17 French and then remove the outer one and pass the access sheath from any company which is plastic, here in this case Cook, and then it goes into the kidney. Then you search for the stone. Watch this. Because I am used to it. Whatever you are used to it, see, like this, you go, turn this, see, this turning is important, this turning. You should not do dilatation. The direction of this thing is like this to the upper calyx, see. Then you are safe. See how much I am towards the leg of the patient. In case you are not able to do it, move the leg to the other side. What is happening? Not able towards the pelvis. You should never aim the dilatation towards pelvis. This is the brake, whereas this acts as the accelerator. See, so the left hand holding the tip of the Alken rod is brake. Even if you are doing single step, this applies. And right hand is accelerator. Brake should be stronger than the accelerator, so that inadvertently you don't go beyond the calyceal anatomy. Rotation movement. See there, you should know limitation where. If you have any doubt, inject. Go inside, see how it is moving. You should be careful. See how it is moving. I am just averting the other wall. Better to keep like this, not like this. It will perforate. If you keep like this, it will go to the lumen. That happens when doing 15 French dilatation. Is it? Okay. I do one step extra dilatation than the amplage passing. Why? See, I will do this. This extra dilatation is because it facilitates easy movement of the amplage. Most of the injuries happen not in the beginning. When the last dilator is inserted, rectus sheath offers resistance. You forcibly put into the system and then suddenly give up comes. That is the time when bleeding happens. So gently dilate one step more, take it out and put the amplage sheath is one more very important point which we follow. Why is I will do this? Why? Ultimately, most resistance part in PCNL is rectus sheath, not the kidney, not the pelvis, and not the other things. Dermis and rectus sheath. They should be liberally incised. Now this is 16. See, small it is. 16 it will go inside. Now it is only rotating jaw, not very. At this stage, if you are doubtful, inject contrast. Then clearly it will tell. Now see, when I am taking out, this is very important. Push the guide wire inside. When you are taking out the Alken rod and dilators, remember two things. One is guide wire slips in supine PCNL so commonly. Push the guide wire in more and hold with the left hand tip. Second is, if the torrential bleeding happens now, take out the amplage. That's all. No putting nephroscope and searching. The torrential bleeding appearance you should be able to easily identify in children. 100 ml blood loss is also not acceptable. This is a child PCNL. He is holding, and torrential bleeding should not happen here. No torrential bleeding, same immaturity. So he will put saline now. And he is pushing inside, otherwise guide wire will slip. So ergo guide wire especially will slip. See, it is coming out. Saline. Mild hematuria, no problem. Let us see how it is inside when the infundibulum, periphery of the calyx is there or not. Very important. When he is pushing, you can suck it out without removing the guide wire. This sucking out of the blood clot and the pus is very important in mildly infected system where acceptable doing PCNL. If you suck out constantly by putting water externally and take out, it empties. Especially initial clot, 1 or 2, I will show this. It will be emptied and stone will be nicely seen. Then you can proceed with this. Supine PCNL, this guide wire is useful up to you enter the system. After that you can take it out because it occupies lot of space. You should always flow water without air bubble. Now I am using 12 French nephroscope from the coral storage through the 15 French access sheath where water logistics will be perfect and distension of the system will be adequate. Some amount of water will be instilled from below ureteric catheter, not very much. Once you go inside, what you have to see is the infundibular mouth. Let us see. Now it's horizontal. You see horizontal. All the supracostal also I can approach. Now I am going inside. He will not flush now. If he flushes, the pressure go close. The guide wire is there upper. I am turning here. Small amount of clot along with the this thing is there. Not torrential bleeding. Now see my body language is changed. I am turning like this. This turning is better with Ampla sheet than with this thing. Now my aim is to go to the PUJ. So if he passes guide wire, this is the stone. Can you see? That's all. This is the stone. The most important point here is this is 1.5 to 1.7 centimeter. Only iceberg of the stone is seen from the pelviureteric junction. This is the most important point why I have selected this case is it is impacted stone. First thing is don't try to pluck it out with tight forceps. Then you can cause avulsion. Second thing I wanted to mention in this case, I have not used laser. I tried only pneumatic lithotripter because it is so much densely impacted. By chance, after removing this iceberg, rest of the stone, if you use and touch the mucosa, it causes damage, whether it is homium or thulium. I will share that. This is a stone. So bleeding is not torrential. Stop. Next. Whether my puncture is correct or not, how will you assess? So you withdraw this slowly, guide wire is not there. You withdraw slowly. You can observe here all the around the infundibulum. And there is no bleeding. Can you see the infundibular this thing? Yes, sir. In children, helix cup will be very small. You will just see this. If you come back, it will be outside. So you are just lateral to the infundibulum. That is what shown in the beginning from the periphery of the helix. How do you is pushing water? You can remove this. You can remove by suction like this. If it doesn't come out, then how will you remove? Yes. Yeah. Now this stone is impacted. How do you break with laser or pneumatic? I prefer pneumatic. You can use laser also. If at all laser, more homium laser, not the thulium laser. So I am using very small like other places. Now he is stabilizing. See, I am breaking. Simple breaking. Why unnecessary laser? Any fragment, anywhere it goes, I can remove it. See, all the impacted stone. Just this is another point here. The tip of the pneumatic lithotripter is much bigger than laser, but stable. Whereas laser fiber is much smaller, you can touch, but unstable. Advantage, disadvantage. If I use laser fiber, it will touch nicely, but the problem is it will wobble and touch here and there. So I tried my level best with pneumatic only. Only when you want to make a small irregular surface where pneumatic is slipping, laser fiber can be used. That also I have shown here. Short pulses. This is less frequency, so that your precision will be good. If you observe carefully, I am not able to visualize the stone very clearly and blasting. That you cannot do with laser. You cannot apply laser without seeing the stone, but pneumatic, sometimes you hug it and break it. That is also not correct. That means this stone has some curvature in the ureter and not completely seen. Then if you try for 10 times, 15 times also, breakage will not be much. This is a truly practical points I am telling. This is not the best case I have done. These are the points which will help the juniors. Now I try to see the lateral, medial and lateral aspects of the stone by moving the nephroscope. That I will share now. Like this. See, this is the time I use a laser to make a small hole in the stone so that I can break it, because the pneumatic is slipping. If you slip and forcibly put it, the stone may migrate perforation. So you should use less force. So make small irregular surface on the stone and then break it, it breaks. Let us see. Just short pulses. That's all. That's all. Now I wanted to take the pneumatic lithotripter, put it in that hole and make it to pieces. You may think, why so much struggling? We easily remove. No, each case is different. This is 12 French nephroscope I am telling you. Such a small nephroscope is not seeing the stone in toto. Only not half of the stone is also not seen. Never damage PUJ.
Laser may be precise, but PUJ may get damage. Tumor injury. So break it properly because pneumatic lithotripter is breaking. There is one small technique where you can use in children. What is the advantage? You drill it, take the pneumatic lithotripter, it will break. This is very safe way of doing the critical areas or I will keep it here because it's weak. We can break through the hole. See. It is broken because it is weakened. You got the point? Now I can take this broken here, but see, this is broken and coming out in total. See, like this. This is what exactly.
Always any piece which is broken at the PUJ, please rotate and remove. Don't remove directly because waste may be there below. That is why I am showing this.
Uses of the laser, but not RIRS. Then why should you do same thing like RIRS? Take out the pieces, not the
dusting.
Not the. This is my version. Lot of people say this as possible. Then you will get the better SFR. That is very important. See now also it is turning so much. See how to when the acute angle is there, how to hold and not to injure the
Mucosa.
Mucosa. Two both show here and there. 3, 4, 5, 6, 7. So what you are creating? You have created a space. Now you take the.
This is very important in this surgery. Fifth point is that when densely impacted, it is taking curve. If you come from the upper calyx, you may have little advantage, but if you come from the lower calyx, you will have disadvantage. If you come from middle calyx, you just move the pelvic wall little so that you create space. Ultimately, the top part of the stone will be seen to break with pneumatic lithotripter. You all know this for only juniors because they will be struggling. They will hold with forceps, remove, bleeding happens, mucosa may damage. For juniors only this video, of course not for seniors who may be more experienced.
Pieces, and those pieces will come out of the impacted area. Can you see that? Can you see this? This. See, now my pneumatic lithotripter is just touching there, and that too not very fast. See.
One important question asked is bigger nephroscope. I must tell you, I am using already 15 French Ampla sheath. There is no nephroscope between 12 to 15 except one company, Shawley 13.9. If you wanted to use next size, it is 18, so you have to dilate up to 20. In this child with a very small calyx, if you dilate up to 20, there will be chance of bleeding. If you make up to 22, you can pick it out. But the problem here is stone is not visible. There is curvature. Larger the access sheath, traveling of the curvature is difficult. Smaller the nephroscope, maybe you can use the laser, but don't try with larger nephroscope because PUJ will be impacted. It will not be of any use.
It has broken. Break it completely. Make pieces. Don't try to deliver the
Into.
Especially with the Ampla sheet. Because Ampla sheet is a like that's why I prefer Ampla. This person may say his own version. Some people are very good in minimal with metal sheet, but I feel, see, it is going down. You should be careful. Okay, because we'll break the stone. Now, while holding, be careful. Not every forceps should be used here. See, rotate.
I am rotating and one large piece is not coming out of the amplage. All you have to wait is just 2 minutes again with Unedited lithotripter. Don't lose patience. This is not pick out stone. In children, don't think pick out stone is good. In fact, RIRS is least invasive, but because of multiple kinks we are showing. Now I have picked up a large chunk of stone which is not coming from the amplage. If it is 20 amplage, it might have come out. But
rotate, and now take it out. Rotate. See, this is a big chunk of stone. If it comes like this, it's better. Okay? It may need one more breaking. Don't mind that. So he is rotating amplage sheet, abutting, and just give the break like this. It's broken. Put on the end. That's all. It is broken. Now we come back. Come back. It is broken. So now pieces will come out easily. See, now this piece will come out easily now. If it is not broken, again you break it. Give me. Why it is, in the laser it is easy, but in Unedited lithotripter it is safe. It is touching above. That's the point.
see, at this juncture, if you use the laser, it is very easy. If any stone in the pelvis, laser is okay. But in impacted deeply curved in the upper ureter, don't use the laser. A lot of important points are there here. That's why we are sharing this case.
Angle of the direction is important when you are doing the breaking. Now you hold it and try to remove. Rotate. Rotation causes easy removal sometimes. Forceps, if it is not strong, don't mind that. In one direction it will come out. So have patience. Now slowly other stone we have to disimpact. This forceps is already here.
This is very dangerous. I am taking a curve in the upper ureter and taking out the remaining stone. You don't know how much thick it is. You should judge carefully. Use biprong or triprong, rotate slowly so that you deliver it. Never pull out in one go.
What I do, this is carefully you should do. You should not use laser in such cases. See, nicely you hold, rotate. See, this is very important step in PCNL. Rotate. Don't try to pluck out. Pluck out is wrong. Rotation is correct, like this. If it is not coming, happily you break. Because it is in the
pelvis.
wall. Invariably some amount of wall will be touched. This is easy case, so don't make it complicated by using the laser. So simply in 15 French, this is what size of the scope this is? 12 French. Which company? Wolf. So Wolf, if you dilate more, bleeding will happen. So judgment is by whom? Still the large part of the waist, if it is there, it won't come out. So let this come out. Gently is flushing from below, absolutely no bleeding. Whatever the time it takes, there is no need to worry about it. See, this is a large piece. I am breaking it with my forceps. Always in children, you have to remember that. You have to send for the
Analysis.
You have to send the stone for analysis. Don't miss the stones. Here, up to this level, it appeared that I am struggling, but it took only 14 minutes. Most important is have patience. Don't pluck out the stone. Don't use laser in impacted stones. Don't use in curvatures laser. They may cause. If it is floating, if it is in the pelvis, all parts of the stone are seen, laser is okay.
Now, how it is It should not go inside, it should not come outside. Now see one more, everything falls now. See if he flushes it nicely, everything is clear, no need for the flexible scoping. Show that I am putting the scope, absolutely PUJ is not.
You see at the end of the 10 minutes, it might have finished in 5 minutes, it might have finished in 2 minutes. But see the PUJ, all the mucosa, rugosities are there intact and there is no damage at all. Then post-operatively, edema will not be there, stenosis will not be there. You will be safe. You can see the ureteric catheter nicely, which was in the upper ureter. Then you are very comfortable. All the fragments you can observe in supine PCNL easily. Once it is completely clear, you will be very happy. It takes only 2 minutes more, where I have not. If you use laser, 1 or 2 years blanching happens. There is a chance of stricture. If it is straightforward, bulk is seen, okay.
Injured. See this picture you take. The obstructing factor is this. This is very important supine PCNL. If he puts in normal position, you can easily.
I am observing the upper calyx now. My leg is coming in the way. This is the commonest problem in supine PCNL. You can shift a little adducted. In fact, if you wanted to do only supine PCNL, leg can be kept straight. If you wanted to do both RIRS and supine PCNL, it has to be little low and flexed. Here, purposefully, the technician is moving the leg. I am showing how it is adducted, and then you can go to the upper calyx.
Go into the
Upper calyx.
So he is changing the position without, see, like that. Now I will turn. See the calyx how I am going. Can you see?
Yes, sir.
This is a complete upper calyx. Any going from the lower, middle to upper calyx in supine PCNL is easy, whereas you have fear of in prone PCNL whether fragment goes. That's why in prone people will prefer the upper calyx. Now, after this, the surgery is over now. To be honest, on the screen it is showing 18 minutes of time. So in 18 minutes of time, supine PCNL is over from the puncture. That is, circumcision also will take 45 minutes. So don't be in hurry when you are doing with PUJ impacted stones, meaty kidneys, they may bleed. Now, rest of the 6 minutes video is a waste, only demonstrating how flexible nephroscope can be helpful, how to use the flexible nephroscope. I am going to use here, no conflicts of interest, Biorad flexible nephroscope 13.5 French. The sheath I have put is 15 French. Water flow logistics will be good. How a 15 French 13.5 French nephroscope goes into all calyces, and the inferior calyx we have not seen so far. Upper ureter we have not seen. Upper calyx we have seen. Middle calyx we have not seen. We can see nicely. So next 6 minutes only extra what we are.
So you see the calyx, and now any stone, one stone was there, that I will see. If this one is the stone, it will come out. If you go like this, water please. If you go like this, it will come out by itself. See, can you understand?
Yes.
So if you rotate and go to the amplas sheet, it will come. This is the pelvis. Now this is the all around mucosa. Flexible scope is there all around mucosa. Now in this we can use the flexible. I am showing how each calyces can be inspected. If the ureter is tight, ECRS cannot be done. Then flexible scope can be used. Flexible nephroscope. How the flexible?
See, now the debate is, if you have a stone in other calyx, you don't want to puncture. What are the two options? ECIRS is flexible ureteroscopy from below. If you are in prone position, can you do that? No. That time flexible nephroscope is useful. Till today, I felt that flexible nephroscope length tip is too much, so that you cannot go to one calyx to other calyx. But now newer generation flexible nephroscopes are coming. They are highly bendable. This is a one case. So this flexible nephroscope will go into all calyces, how I will show. And you can use basket and bring back to the pelvis and take the rigid scope and finish, so that prone PCNL with flexible nephroscope is a competition to ECIRS. I am I am a proponent of ECRS, but I am showing the other method. So you should be open-minded. You should not say that I will do this only. This is the best. That is the best. No, every case is different. You have to go accordingly. See it. In flexible digital nephroscope, this is. There is no marking on the top. See, I am going. I am going into the pelvis. How I am going in pelvis? You need experience. Or else simple idea is take the help of the CM. You will really be comfortable. And you have to do little bit of awkward movement also. Sometimes it breaks also. You need little expertise to use the flexible nephroscope because the distension of the pelvis will not be that much as it is in the flexible ureteroscopy, as it is in the nephroscopy. Now you see here, I am going into the pelvis, I am going into the ureter, I am going into the mid-ureter. The 13.5 French has gone up to mid-ureter. What does it mean? No stones distally. Very happy. Now I am going into the middle calyx nicely. Now I am going into the extreme middle calyx nicely. Now I will go into the upper calyx also, coming back a little bit upper calyx. Now I am going into the inferior calyx, which is present anteriorly. See, look up. I am seeing up now, and this is all cannot be appreciated easily. See, this is up. So for this, the ampla sheet should be at the edge of this. See, this is the pelvis. This is the pelvis. This is the clot. Now I am going up towards the 12 o'clock position. That is the inferior calyx, which is more anterior in supine PCNL. This is the inferior calyx. See how nicely the calyx is seen from the pelvis. That means just below the amplage, you have so much maneuverability to go to all the calyces. In this case, I am not suspecting any stone after so much. So complete clearance is done. It's not a difficult case. It's not a large stone. But for this patient, aim is to completely clear so that recurrence does not happen. If you want to check on CM, you can inject contrast from below and check. But that is only for academic purpose. CM usage in children must be lessened. Come out. At this stage, I should come out actually. I should not do anything more than in this case. But out of enthusiasm for this class, I have injected contrast and shown the inferior calyx again. See the ureteric catheter. See the again ureter, upper ureter. Nothing great. By doing repeatedly, you will not get any. See how easily the 13.5 is going. But rigid scope does not go because it will have torque. Bleeding can occur. In this case, bleeding will never happen. So here, combination of flexible cystoscopy I am showing is because the latest flexible nephroscope or cystoscope are highly flexible with this tip. This is from the Biorad. Let any company, future another company may come. See the air bubble shows the top. Top is inferior calyx. In supine PCNL, topmost is inferior calyx, just below the peritoneum. Just below the peritoneum. In fact, I told to keep the CM here. I don't know whether it is kept the CM or not. I have only another 2 minutes. After that, the live transmission will go. In future, the complete live transmission while doing surgery may not have this much discussions possible. So future generations in Western countries are going live surgery with discussion by senior will give a lot of insights to the juniors. That's why this is the first time I am showing the semi-live where everything is unedited. See, so much time I am wasting. Here actually the CM might have been shown. It is not shown. I am repeatedly going and showing all the calyces out of enthusiasm. See how upper calyx, compound calyx is there. So these are all very narrow angled. At the end, if you want to inject contrast. Now, the next question is, last part of the discussion is whether to put stent or nephrostomy. What will happen if the stent is put? Patient will nicely go. He will have some frequency urgency, but after 12 days, you have to give anesthesia in children to remove it, 5 years child. Whereas if you put nephrostomy, It will drain the kidney for 1 day, no contamination, no fever. After that, you clamp nephrostomy for half an hour and then open and then remove, so that ureteric catheter will be there for 1 day, so that ureter will be technically open and stent removal can be avoided. That's what exactly I did. I will show that. Now, after ensuring that all these stones are removed, all the calyces are free. Children calyces are very, very simple. 3 calyces will be there. Infundibulum long length will not be there. PCNL one should be careful. And now I put nephrostomy and fix and come out. And this patient is already nephrostomy removed. Foley's catheter will be removed and will be discharged. So no fever, no complications. So on table only you can tell where you are and how it will be. One more thing important is when you put the nephrostomy, these are the stones which are removed, not very bulky but safely removed. Don't do powder. PCNL is pieces, RIRS is powder. If you do PCNL powder, then you are doing mimicking RIRS, again some powder may be there. That's why most of the pieces I try to remove large pieces. So with this, our presentation, actually external video of nephrostomy fixation is nothing great. Inject contrast. One advantage of nephrostogram is that dye trickles by the side of the nephrostomy and it will show whether colon or pleura is injured. That is a very valuable information I have done in this case, but it's not incorporated. The video ended here. I thank once again. I will give 2 to 3 minutes of time. I am stopping sharing so that if anybody wants to ask any question, this is total 24 minutes of surgery, which is very, very, very less for anesthesia point of view. It is supine position and no need to confuse wherever. Everything I told. I'm a crazy lover of laser, but I have not used laser here. I am very, very good at RIRS in pediatric, but I have not done in this case. So every case is individualized. Guidelines will only guide you, but you have to make on the table with your experience, which is better for the patient, especially consider socioeconomic status. Don't charge the same for RIRS and PCNL. They are different surgeries. PCNL bleeding can occur, but properly done puncture, unlikely you will get severe bleeding with 15 French dilatation. So if any questions, welcome. And please tell your friends to join the Pure. Tomorrow and coming years, the education will predominantly be online, and most of the teachers may be interested to show online instead of spending a lot of time and a lot of the resources for the live workshops. That's why after a long time in Pure Urology, I am doing this program. I once again thank you for watching this program, and I wish the juniors will get some points out of this supine PCNL surgical technique video in a pediatric patient. Thank you very much. We will conclude the session.